Hi there, everyone. Thank you for coming tonight to our clinical seminar for mental health providers and other mental and physical health care professionals on helping the helpers, self-care for mental health providers. For those of you who are new to CMHRC, I'd like to take a moment to introduce myself. My name is Elizabeth Errico. I'm the Executive Director of the Children's Mental Health Resource Center. Our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype dubbed fear of harm. This work that we do is focused on both families as well as providers so that we can provide resources to both. Mood disorders, bipolar, and FOH in children and teens can be difficult to identify and treat, which can also mean that it is very isolating for families who are living with it, as well as for providers who are trying to treat these complex cases. We are a national nonprofit organization. We rely on the generosity of our donors and sustaining members to make our work possible. So if you value the work that we do and appreciate our free programs and services like this monthly clinical seminar, which is free of charge, please consider making a gift in 2024. Donations can be made through our website at cmhrc.org/donate. Tonight, we are going to be talking about how we can engage in professional self-care. During the course of the presentation, my colleague Jennifer, who is CMHRC's clinical director, is going to be responding in the Q&A. So please feel free to put questions, comments, thoughts into the Q&A for her. She'll be saving some, and we're going to try, if time permits, to have a live Q&A session at the end where she will relay your questions and she and I will discuss their answers. But for tonight, we are going to focus on the following learning objectives. We are going to focus on understanding what burnout is and what causes it for mental health providers, the purpose of self-care for therapists and other mental health professionals, the difference between personal self-care and professional self-care, and what some of those best practices are for professional self-care. And then in that Q&A, we'll also be able to touch on how to put some of this into practice. Now, burnout versus compassion fatigue. This is an important distinction to make. They're both terms we're probably all familiar with, but and burnout is, of course, applicable to far more than just mental health professionals, but it is particularly problematic for us because of the work that we do. Now, burnout and compassion fatigue are not the same thing. Burnout is a term that is used to refer to general exhaustion and a lack of interest or motivation regarding one's work. But compassion fatigue is also known by another term, vicarious trauma. And but compassion fatigue refers to negative emotions that individuals feel as a result of their work helping others. And so burnout is a part of compassion fatigue. It's sort of a slow onset of feelings of hopelessness, feelings that our work doesn't have a positive impact on the field, on the people that we are attempting to help. There's also a component of secondary traumatic stress, and that usually involves a much more rapid onset of symptoms that mirror PTSD, such as nightmares, difficulty sleeping, and intrusive thoughts. Sometimes these thoughts are about topics that our clients are sharing with us, and sometimes it's about the experience of treating clients and being involved in mental health care. Burnout and compassion fatigue also differ in terms of where they come from. Burnout is from occupational stress and overwork. Compassion fatigue, on the other hand, comes directly from the work, helping our clients very often, especially in this day and age with a focus on trauma in the field. It can come from working with victims of trauma. Now, the signs of compassion fatigue can be seen in our personal lives as well as in our professional lives. On the personal side, we see compassion fatigue in the following personal areas. There are physical, emotional, behavioral, spiritual, cognitive, and relational symptoms of compassion fatigue. The physical include headaches, fatigue, or a weakened immune system. We may find ourselves getting sick much more frequently when we have compassion fatigue. The emotional includes feelings of powerlessness, anxiety, helplessness, and distress. Now, we may feel these things very legitimately because we're helping people manage things that are beyond our control. And so we don't have any power. But this is distress, anxiety, powerlessness, and helplessness that goes beyond what would be reasonably expected based on the reality of the circumstances. Behaviorally, we can engage in hypervigilance and experience change in our eating and sleeping habits. Spiritual symptoms include feeling a loss of purpose and no longer deriving a sense of meaning from our work. Cognitively, we can experience inattention, reduced concentration, feelings of pessimism, which can be seen in our work with our clients when suddenly we're finding ourselves not paying attention anymore or having difficulty having empathy for the experiences our clients are relaying to us. Relationally, there is social withdrawal and mistrust. In the workplace, the symptoms of compassion fatigue specifically are identified as relating to performance, morale, again, relational and behavioral. Now, performance involves low motivation and potentially low quality of work and general forgetfulness at work. We may see this in forgetting to do our progress notes, our other charting, feeling reluctant to take on new clients, and generally feeling like we're not giving our clients the best possible care. Morale can be demonstrated through apathy, feeling disconnected, undervalued, and unappreciated by our employers and or by our clients. And relationally, we start to withdraw from colleagues or find that we're engaging in more conflict-driven behaviors with them. And behaviorally, it can be seen as calling out of work, being late, or having an irresponsible or careless attitude towards our work. The scope of this problem, well, the statistics on this are rather bleak, and they're not going to be a surprise likely to any of us. In 2012, there was a study done, a sort of a review of studies that showed that 21 to 67% of mental health workers might be experiencing high levels of burnout. And that burnout leads to staff turnover, disruptions in the continuity of care, reductions in empathy, collaboration, and attentiveness to clients' needs. It results in negative attitudes towards the consumers of mental health care services, namely our clients and patients and the people that we're there to help, which in turn leads to poorer treatment outcomes with those who are in treatment for their mental health challenges or mental illness. So, how many of us are surprised by this? Probably none of us. This data comes from 12 years ago. So, if you're wondering what the statistics look like now, we find that studies done as recently as 2020 show that 78% of psychiatrists self-reported feeling burned out. 90% of all college counseling center providers self-reported burnout. And in 2023, social workers reported a 75% lifetime burnout rate and a 39% current burnout rate. That means over the course of a career, 75% of social workers experienced burnout. And right now, at this very moment, 39% of all practicing social workers are experiencing burnout today. These statistics are sobering. We also see studies coming out of the US Department of Health and Human Services that are showing us that in 5,733, very specific number, but roughly 5,800 areas geographically in the United States are experiencing a shortage of mental health professionals. And that on average, there is less than one mental health care provider for 30,000 people. So as a field, we've responded to this tremendous need in the population by expanding our work hours, expanding the number of clients that we can see on our caseloads in the hours that we are at work, by adding waiting lists, bumping paperwork, charting requirements, insurance requirements, pushing that to what used to be non-working hours so that we can increase the number of clients we're seeing when we're physically on the job. And we're blaming ourselves for underserved communities having inadequate access to mental health care services, while states cut billions of dollars from mental health care resources. So you're probably thinking, tell me something I don't know. So let's focus on some solutions to these issues of burnout. What do we do as therapists anyway? What is our purpose? So our hearts and our minds are our primary tool as therapists. We learn strategies, we learn techniques, we learn theory and information that informs that work. But ultimately, it's our job to sit with a client, to experience empathy, to share their experiences, and to guide them on their journey towards stability, recovery, and an improved quality of life. We cannot do that if we are burned out. Period. End of sentence. Without the capacity to attend to our clients, without the capacity to feel compassion and empathy for what they are going through, it is impossible for us to do our jobs. Now, remembering that it is part of our humanity that adds to our ability to do our job doesn't necessarily mean that we have to be expected to give all of ourselves to our work. In fact, taking time to separate from our work and to nurture ourselves as individuals on the personal side of who we are as people is actually an essential part of being able to do our job well. It's like the reminder from the airplane to put on our own oxygen mask before we help someone else who needs assistance. Probably every mental health professional out there has used this analogy with their clients and patients at some point, but how frequently do we apply it to ourselves? I'm going to go out on a limb and say probably not enough. So we do have to take care of ourselves personally, protect our personal time and our personal life, while also enriching ourselves professionally so that we can remain engaged and connected with our work. We call those our professional needs. And taking care of our professional needs, engaging in professional self-care, is incredibly important as a provider for us to be able to maintain long-term commitment, engagement, and connectedness to the work that we do. So, professional care, self-care involves having our own private therapy and an annual psychiatric checkup. It requires we set and maintain good professional boundaries, that we engage in regular peer supervision and discussion, that we stay current on changes in the field and regularly attend trainings, that we make sure to use the right tools to support our work, and that we remember to keep a balanced caseload. Now, we're going to go through and talk about each one of these in turn so that we can take a slightly deeper dive into each topic. So to start with, private therapy, not supervision, but true individual therapy for ourselves as providers to process our own trauma, our own stress, our own personal challenges, both past and present, is essential to maintaining the clarity of mind that we need to ensure that our interactions with our clients are focused on addressing their psychological needs and not our own unattended psychological needs. This isn't something we ever intend to do as providers. We never go into a therapeutic relationship with a client thinking, aha, this is going to serve me as an individual. But it happens unconsciously over time when we don't have the personal support that we need. We wind up slipping into therapeutic patterns that serve us in a countertransference, to use a Freudian term, way that serves us rather than serves our clients. And when we're doing that, we're no longer doing our jobs. So private individual psychotherapy for ourselves will allow us to ensure that when we are working with our clients, we are working for their psychological best interests and not our own. This is also true for having an annual psychiatric checkup. That may seem strange to many of us, but the truth is, just like we have a physical health checkup every year, we should be having a psychiatric checkup every year as well. Burnout, as we know, is all too real, and compassion fatigue is also a plague on us when we are in this helping profession. And so it is very easy for those feelings of frustration, helplessness, hopelessness, and relational withdrawal to drift us into the territory of actually experiencing a mental health disorder ourselves, such as a mood disorder, major depressive disorder, generalized anxiety disorder, and others. So getting our own psychiatric checkups each year is an ethical foundation of being a helping professional. I saw someone raised a hand. Please go ahead and put your questions into the Q&A. Jen will answer them as we're going, or she'll hold them and we can ask them at the end for discussion. So, good fences make good therapists. Just like with our physical health checkups and our psychiatric checkups, we have to make sure that we have good boundaries between us and our clients and patients, but also that we have a good set of boundaries between us, our personal life, and us in our professional life. There are small, important steps that we can all take on a daily basis to support setting and maintaining healthy professional boundaries with our work, including some really basic things that we all probably know already, but we take for granted and forget to do. And so it's good to have a reminder of them. They include the simplicity of leave work at work. Which feels harder to do than to say in our modern life, where we have the portability of devices that allow us to stay connected. So part of setting a good professional boundary is to only text, email, and return calls from clients during set working hours that are also posted so that our clients understand. Setting up contracts at the beginning of a therapeutic relationship, establishing that text, email, and calls will only be returned during specific times, directing people to 911 during your off hours is extremely important for setting those boundaries early and firmly. We can do this by using a separate set of computers, tablets, or cell phones for our work and turning them off completely when we are in our personal time or literally leaving them at the office. I'm reminded of what this field was like many years ago when I was starting out. We had desktop computers at work, which were the antithesis of portable. Most of us needed to have the IT guy come and tell us how to plug in the mouse. So the idea of unplugging it all and taking it somewhere else would have been utterly daunting. We didn't have cell phones. We had voicemail on a phone that sat on our desk. And so when we weren't at work, we weren't reachable. And that was understood by our patients and clients. It was understood by our supervisors and colleagues, and it was understood by us. And having that separation is extremely important. Part of the continued burden that helping professionals take on is connected to our desire to be of service to our clients and our patients. But remembering that we can set a boundary where we're only engaged with them during our working hours helps us maintain our professional self-care, but it also has benefits for the client and decreases the likelihood of the developing of any sort of codependent relationships. And again, in terms of being transparent about these boundaries, using email signatures and auto reply that let folks know when you're unavailable is extremely helpful. It's also really important to take a lunch break. I think this falls into the category of things that we know and take for granted but forget to do. Oftentimes we'll sit at our desks and eat our lunches while we're doing charting or while we're reading text messages or emails from clients, or we're on the phone with someone. Take a lunch break. Leave your office. Step outside. Take a short walk. Have a cup of tea in the park. Take a few minutes to just look at the world that is going on outside of the office. It can have an immensely restorative effect and be very good at reinforcing those professional boundaries. Another strategy for establishing boundaries is using meditation techniques to separate one's mind from one's work as one goes home. If you take public transportation, a bus, a train, a subway, or even if you commute and are on a road that has traffic lights or exits on off a highway, or different streets that are landmarks that you can engage in a conscious meditation where each time you get to a new train stop, a new traffic light, a new exit off the highway, you imagine yourself, the reality of your physical self and emotional self, getting one step further away from your office and away from the demands and stressors that reside there. It can be very helpful that by the time you get home, you will feel as though that umbilical cord to your workplace has been cut. Using commute time to catch up on phone calls is going to have the opposite effect. You're going to get home and feel as though you're still at work. So that type of meditation can be extremely helpful. Our next topic is the value of peer supervision. Now, no one can deny the value and importance of supervision in our professional life. Support from a supervisor can make all of the difference in terms of being able to function in a busy clinic or school, and knowing that your boss has your back, professionally speaking, and can help you think through cases is truly invaluable. But as burned out as providers are, our supervisors are just as burned out, if not more. And so supervision is often the very first thing that gets rescheduled or canceled when there are time crunches. This is part of why peer supervision can be such an important part of the professional self-care toolbox. Peer supervision is different from regular supervision in that it's a group of providers who are all, hierarchically speaking, on the same level. And so it provides a very different type of professional opportunity for us to develop as mental health care providers. Benefits of peer supervision can include an increased access to collaboration, and sort of the complex and wonderfully intellectually stimulating exercise of sharing experiences, sharing clinical experience from other providers that allows for us to learn vicariously through them. Peer supervision provides us the opportunity to focus on our not only our clients and not only our day-to-day work, but it can also allow us, because there is no hierarchical structure, to focus on our self-assessment, to assess our skills, to find opportunities for our colleagues to sort of fill in the gaps of our individual knowledge and understanding. And it offers us the opportunity to get interdisciplinary perspectives and to learn from related areas of study that may not be represented in our one-on-one supervisor-supervisee relationship. So for example, when we combine social workers, occupational therapists, LMFTs, psychologists, and nurses, all in the same peer supervision group to review cases, to discuss interventions, to plan strategies, and develop treatment plans, our perspective is broadened. And it in turn broadens the approaches that we take in planning treatment plans and executing them for our clients. Our whole approach in an interdisciplinary peer supervision setting improves the quality of care that we can provide to our clients and patients. Now, peer supervision works best when we are not feeling excessive pressure about it, when it is not tied to our job performance, where it is truly an opportunity for professional growth, development, and self-care. So having a realistic but regular schedule that we can commit to attend is extremely helpful. It also helps and works best when we are sharing different theoretical orientations and training backgrounds. To be in peer supervision with only other individuals who are trained in trauma-informed treatments is actually quite limiting. To be in a peer supervision setting with other professionals in mental health, some of whom might be trauma informed, some of whom might have a psychoanalytic background, some of whom might be focused on cognitive behavioral treatments, and some of whom may be focused on long-term psychoanalysis. Some might be focused on the physical and medical interventions that we can use to alleviate client symptoms. Having those different orientations and training backgrounds is extremely valuable. It also helps when we can bring complex cases for review. This can be done outside of our workplace with complete HIPAA compliance and maintaining anonymity for our clients, but still being able to bring in cases for case study discussions, for case reviews, or for what in the medical community is usually called grand rounds. During these peer supervision sessions, they go best when the focus is on sharing and developing professional competence, professional skills, and sharing support amongst providers. Now, Peer supervision is fundamentally peer support. We are there to share and accept alternative perspectives and novel ideas. We're not there to compete. We're not there to demonstrate that one theoretical orientation or certification model is better than the other. We are there to share and accept alternative perspectives and novel ideas. We're also there to develop a community through collaboration and accountability. And peer supervision as peer support is a place to bounce ideas, explore options, and gain insight and clarity. These intellectual exercises have tremendous value for us as providers in how it opens our minds to new possibilities. Now, peer supervision and the so-called unicorn diagnoses. If you weren't trained in certain diagnoses, it is most likely that others weren't either. So we are taught still that there are certain unicorn diagnoses, certain very rare diagnoses, many of which include mood disorders and bipolar disorder in children. There's also, as it relates to the work that we do, the newly identified phenotype of bipolar that's been dubbed FOH. No one's been trained in that in graduate school because the researchers are still working on it. So no one that you work with is going to know what it is. Peer supervision with other folks who have been trained in how mood disorders present differently in children, how bipolar symptoms differ from the adult criteria listed in the DSM, and how to identify and treat FOH is extremely important. And peer supervision can allow you to collaborate and consult with colleagues who are not restricted to your workplace or geographic area. They are nationwide, and they have made sure that they are trained in and versed in these diagnoses and their treatments. And so they're able to share that information with you, and you become a resource to one another, which then enhances your ability to treat clients and patients with a degree of effectiveness you didn't have before peer supervision. And it's just a wonderful experience to join a network of practitioners who are there for no other reason than to support one another. The opportunities to do that do not present themselves frequently enough in our field. Now, when we talk about trainings as a part of professional self-care, one of my colleagues, Steve, put this best. He said, this is not a static profession that we're in. Things are evolving and they are changing. This is extremely true. What we learned in graduate school, whether it was 3, 5, 10, 15, or 25 years ago, isn't necessarily what's current. And so going to trainings, making sure we're up on the latest trends and ideas in the field is extremely important for fighting off that burnout and making us feel as though we're connected to our work. And yes, most of us, we have to get continuing education credits. We have to be able to maintain our existing certifications. But focusing only on CEUs and on certifications is actually quite limiting. Yes, we have to maintain our state licenses, and we have to maintain good standing with our professional associations and governing bodies and whatnot. But the truth is that when we focus only on what we can earn a CEU for, or what we can earn a certification in, we are cutting ourselves off from everything that is new, that is groundbreaking, that is cutting edge. Because that is essential for us to truly stay current in this ever-changing dynamic field. So we need to look beyond that and beyond the familiar to find new ideas, to learn about new research, to understand novel approaches that are currently being studied and tested and put into practice, lifestyle interventions, and new clinical approaches that weren't part of your training programs. The truth is that too often I hear from providers, they literally say, I don't have time to learn anything new. That may be true, but it is certainly not best practice. It is certainly not professional self-care, and it truly needs to change. Now, another aspect of professional self-care is making sure that we have the right tools to do our job. You wouldn't try to dive without water. And you can't try to practice as a mental health care provider without the right professional tools. And professional development resources are an important part of that professional toolbox. Having the diagnostic tools that you know have high validity and reliability are extremely important. Having supportive colleagues that you can turn to for insight, feedback, and new ideas is an important tool to have in your toolbox. Tools that support your ability to communicate with your clients effectively and gather the information that you need when you need it is extremely important. And we also need support around paperwork and reporting requirements. Lastly, on this list of professional self-care strategies is something that many of us don't think about, and it's having a balanced caseload. This is an important tool for mental health care providers. We need to have a variety in the work that we do in order to stay intellectually stimulated, to stay engaged, active, and enthusiastic about our work. It is very easy for us nowadays with specialized certifications to find a niche for ourselves. And once we find that niche, we can find after a few years that it's turned into a rut. We get known in our local community as being a trauma specialist, or as someone who works well with kids, or someone to go to for marital difficulties. But there's an old adage that the reward for good work is more work. And what we find after a while is that our entire caseload represents sort of the same type of client, the same type of issue, the same type of challenge over and over again. So that while it's still a challenge for our client or patient, it's no longer a challenge for us as the provider. It's become rote, it's become boring, it's become so familiar that we cease to see variety and diversity amongst our clients. And instead, it starts to feel as though our days and weeks at work are all one long, never-ending session. A healthy balance can be obtained by varying the ages of the people that we work with, having some kids, some teens, some young adults on our caseloads, or having adults, couples, and families on our caseloads. And some providers may tell you that this approach dilutes your brand. But there's another old adage, and that is that when you're a hammer, everything's a nail. So varying our caseloads not only helps us stay engaged in our work, but it also prevents us from seeing every client who walks through the door through the same lens. When we do that, we are unconsciously making assumptions about what brought them to us. We are unconsciously gravitating towards the same diagnoses over and over again, and gravitating towards the same treatments over and over again, when variety in treatment may be what is necessary, because you're actually seeing people with different problems and they're not all the same. Now, there are ways that we at CMHRC can help you with professional development and self-care. And the truth is that that's not a coincidence. CMHRC was founded by mental health care professionals who saw a need not only in the client and patient community, but in the professional community as well. Our programs and services are designed to provide support to mental and physical health care professionals who deal with and treat kids. So this is very literally by design that we have the capacity to provide professional self-care and professional development support to mental health care providers. So let's look at for a second at what some of those things are. We have developed the following programs and services to assist in professional development. We offer once monthly 90-minute professional discussion groups and peer supervision. So all of those benefits that we've just talked about that go along with having peer supervision, we offer in our monthly professional discussion groups and peer supervision sessions. We also provide a service that we call our diagnostic consultation for providers. In this service, what we do is we do what you don't have the time to do and wish you did. With your overburdened caseloads and your lack of time to do all of your paperwork, what we are able to do is we are able to partner with providers and do complete case reviews of any client or patient that they wish and come back to you with, yes, we think that your diagnosis is correct, or these are some diagnoses that you might have considered. We do a complete differential diagnosis process and provide you with the results. We provide you with research papers that demonstrate information on best practices and provide resources that you can in turn pass on to your clients to help them when they are not in the office with you. This documentation and support of best practices that we provide you can also support you in any requirements that you may have to demonstrate to a third-party reimbursement, like an insurance company, to demonstrate that this so-called unicorn diagnosis you've provided is accurate, and that the course of treatment you're recommending and the number of sessions needed is actually necessary, and that you can then be reimbursed for your work. We also have the CMHRC Toolkit. We have two versions of this, one for providers and one for families, and providers can share this with families and individuals with whom they work. This toolkit is a way for patients and clients to document the frequency and intensity of their symptoms, their diagnoses, their medications, their medication compliance, narrative summaries of how their day went, and all kinds of information that they can then choose to share with you through your provider access to the toolkit. When you have provider access, providers are not upcharged for the number of clients and patients who work with them using this tool. This web app, providers, you pay one fee for a monthly access. It is less than the cost of Netflix. It is easy to access, easy to share with your clients, and it will allow you in crisis, when you haven't seen someone for a while, or before they walk in, to catch up on how their week or 2 weeks or month has gone since you last saw them, by actually looking at their self-report of their symptoms on a daily basis. It is an unbelievably invaluable tool. We are incredibly proud of this proprietary app that we developed, and it is an immeasurable resource and value to providers as well as to patients. We also have these free monthly webinars and clinical seminars that expand your knowledge base and hopefully also expand your comfort zone a little. And after 6 months of attending our professional discussion groups or engaging in a consultation with us, you will get a vetted listing in our national provider referral network, which many providers do find to be incredibly useful because it allows patients to know that they are getting someone who has been trained in how to treat these disorders and identify them in children. Now, I'm going to show you two quick videos. The first is on our toolkit, and the next is on our diagnostic consultation service. You can also find both of these videos. Oh, actually, you know what? I'm not going to show them now. We don't have a ton of time for to get to the Q&A. So I'm going to skip showing you these here and just tell you, go to our YouTube page, just search for CMHRC YouTube, and you can look at our video showing our toolkit, what it does for providers, what our provider diagnostic consultation is. We have many other videos there, and we are adding more every day. Let's see. We're going to move on to, these are the works cited in this presentation. When this is posted next month on our YouTube channel, you will be able to pause the screen and look at these works cited and look at them directly yourself if you would like. Now, for those of you who would like to have some certificate of completion for having attended today, what you can do is you can email us at programs@cmhrc.org. That's programs@cmhrc.org, and let us know if you are a provider, professional, or whether you were a family member who attended today, because we have different certificates to send you depending upon which you are. You can find out about our programs and services and all of them that we offer on our website under the menu tab Services. You can join our mailing list, make a gift, become a sustaining member, or contact us through our website under the menu tab CMHRC. You can find our schedule of free webinars, clinical seminars, and our book club, which meets once monthly. This month we are covering The Explosive Child by Dr. Ross Greene. Those are listed under free resources on our website. And if you would like to make a gift to support the work that we do, you can become a sustaining member with a recurring monthly gift, or you can make a one-time gift, both through our website, cmhrc.org/donate. Now I am going to escape from this screen share and ask my colleague Jen to join me on the screen so that we can see what has transpired in the Q&A. Jen, again, this is Jennifer Sevick, CMHRC's clinical director, and she is has been looking at the Q&A as we go. Jen, what questions came through and do we need to address?
Well, one of the questions, real quick, just asked if you could share that resource list again, Elizabeth. And
the resources that we have at CMHRC? Sure thing.
I believe so. Yeah.
I'm going to pull that up and then screen share that page for everyone.
And then we do have a question of, why go see a psychiatrist if we have a therapist and we're going to see them regularly, and that professional doesn't have a known diagnosis? What is still the benefit of actually going to see a psychiatrist every year?
So Jen, did you answer this in writing for folks? Because I'd love it if you could share your answer with the whole group.
I did not answer it in writing, but I will share my answer with the whole group.
Please.
It's really for a couple of reasons. Sometimes you could have something unidentified that may be going on that is newly developed, new stressors that are going on, but it also is professional protection. In our malpractice insurance every year, we sign that, yes, we are absolutely capable of still, being able to practice. And if there's ever any question as to that, we all experience things like divorce, grief and loss and different things. And this is sort of a way of saying, you know what? It's not just my personal opinion. I have also an MD who has been tracking me, who's been following me, or a psychiatric nurse practitioner. And they gave me a clean bill of health. I'm perfectly capable of being able to continue on. And so it's just a way of every year. And it's not even about that particular year, it's you've been doing it every single year faithfully. It shows in good faith that you're doing everything you can to take care of yourself personally and professionally.
I absolutely agree with everything you said. I would also add that sort of in addition to the sort of protective aspect of it, it also allows us to catch any problems that might be developing early so that they don't then become something that negatively impacts our practice. So as I had mentioned before, you may not have um, ever had clinical depression. But if you're experiencing extended burnout and compassion fatigue, you may discover that your symptoms of burnout and compassion fatigue are starting to mimic that of major depressive disorder. And wouldn't it be good to catch that as early as possible so that you can go in and say, I'm experiencing this. Help me parse this. Is this that I am fatigued and need a break from my work? Or is this that I'm developing major depression? Could be symptoms of generalized anxiety. It could be symptoms of PTSD. It could be symptoms as, quote, mild as just difficulty sleeping and eating. If that starts happening, if you find you're gaining weight or losing weight without intending to, if you find that you're dreading going to work, if you're finding that you don't want to socialize afterwards, if you're experiencing those symptoms of compassion fatigue and burnout, those are also symptoms of mood disorders. So get yourself checked out. And as you said, you don't have to wait for that to happen. You can do it every year as a preventative measure so that you have a documentation that says a CNP, an MD, a DO, somebody who is a medical professional with different background than I do has given me a clean psychiatric bill of health. And it's really a tremendously valuable resource for us in terms of being able to practice with confidence.
The other thing, Elizabeth, as I sit here and it just came to mind is that, psychiatrists who have that medical background or even a psychiatric nurse practitioner, that losing weight unintentionally or gaining weight unintentionally, sometimes if we're seeing a therapist, we may attribute those things to anxiety, depression, and it makes sense to us. But there could actually be like another medical condition that is happening that they have more information. And so sometimes, cancer happens or other things happen, and those are signs and symptoms. And where we dismiss them as that's anxiety or that's depression, and that makes sense given, what I do, they might see something else. And so they're going to partner with your primary care provider, and going once a year to them in addition to a therapist really just makes sound sense.
Mhm. Absolutely. Absolutely. Anything else coming up in the Q&A or in the
Um,
chat?
yes. So, there are some people who say, but I don't have control over my caseloads.
Mm.
And they can't just quit. That's just not their
Oh,
reality. So,
certainly not suggesting that you just quit.
Yeah,
So
what do they do if they don't have control? Like if you work at a community mental health or a private practice and you're just you have absolutely zero control and you don't have time in between those clients to call and coordinate with social services or the school because you have people scheduled back to back to back to back. What are some thoughts that they can do for self-care and for taking care of their clients' needs?
so um yes, we there's something that I learned many years ago from a colleague, and I don't think it was unique to us, but this idea that in any situation you have the choice to leave it, change it, or accept it. Sometimes you're right, we can't just quit our jobs. That's not realistic. So we can't necessarily just leave. Um, but what tools do we have to change? A lot of us feel as though we have our caseloads dictated to us. We don't have any choice. Um, but is it worth a conversation with your supervisor to say, "Hey, I've been getting all of the I don't know, I've been getting all of the 12 to 16-year-old girls on my caseload. Um, could I get some 8 to 12-year-old girls, some 12 to 16-year-old boys?" Having a conversation with your supervisor about what you want your caseload to look like may not result in you getting what you're asking for, but it is more likely to result in you getting some changes in it than not asking at all. Um, so that's one way that we can attempt to change. We can also, in terms of the fact that we have cases back to back to back, setting boundaries around how much time you're going to spend outside of your assigned work hours to get charting, insurance paperwork, and the like done, phone calls to coordinate. That's also really important. When we allow it to just sort of drift and take over, we just sort of fill our briefcase and go home and sit in our living room and work instead of sitting at our desk at our office and working. It really doesn't change much. It doesn't give us that relief from the work that we imagine it will. I kind of think we all learned this the hard way during the pandemic. Working from home is certainly more convenient and cuts out the commute, but it actually has a drawback of fewer boundaries. So if you can, have the ability to say, "I'm going to only spend an hour and a half a night outside of work on my work," and setting a timer, and when it's done, packing up and putting that work away, is extremely important. Because let's face it, if you're sitting here and listening to me say this and thinking, "Well, she just doesn't understand, because if I don't finish that charting, then I'm going to get written up by my supervisor," then we have a systemic problem in the field of mental health with providers being underappreciated, underpaid, under-resourced at work. And we know that this is happening. I mean, I'm not saying anything, brilliant or new. 75% lifetime burnout rate for social workers. That number is not different for LMFTs or LPCs or LMHCs or any of the other folks who are working in mental health care. It's there for all of us. So pushing back a little bit on your supervisors and saying it's not reasonable for us to be expected to spend 2, 3 hours a night or 6 hours on a Saturday at home doing the charting. Um, you know, the time for that is now, and we can start to see what we can do to make change in that arena. And it's not easy, but being able to turn to colleagues who are experiencing the same thing and
Mhm.
vent. And I'll be honest, our professional discussion groups and peer supervision groups certainly involve case consultation, no doubt, but it also involves some venting. And it helps to vent with people who don't work at the same place you do, because then it doesn't become toxic. It's not about directing your frustration at your boss or the board of directors or the people who are in the appointment scheduling department who just keep dumping people onto your caseload. It's about talking and collaborating around the frustrations that we face as providers in this field. And there's tremendous value in being able to carve out an hour and a half a month for yourself to say, this is going to be my professional time to talk about my career and my work with other people who are working in the same space, but not at the same place. Jen, I saw you nodding your head. Did you want to add something to that?
Oh, no, I was just thinking as you were talking about, there's a way to get together with your colleagues to express concerns in an appropriate way and coming together as a group to say, as a group, we find this caseload unmanageable. As a group, we have done the research about what is, a more manageable caseload and what time it takes for the documentation and what is a reasonable expectation for administrative time so that we can get all of our other duties again taken care of. And so it doesn't have to be an us against them situation, but it can be a collaborative approach to saying, hey, this is professionally what it takes for us to continue to be able to serve this community in the best possible way. Because those really are real concerns that do lead to compassion fatigue, really burnout. So I do hear people when they say that this is their reality that they live in for sure.
Absolutely.
Yeah, it's a hard one.
Other questions that came up?
Besides, when we're not actually doing CEUs for credit for our licensures, what other resources do you recommend that people can look to learn and to further their knowledge about mood disorders?
So it might sound self-serving, but our free monthly webinars and clinical seminars are designed to do exactly that. So for example, some clinical seminars we had last year that were very, very much appreciated by the professional community were things like, can bipolar exist in children? And if so, what does it look like? How do I differentiate between bipolar and ADHD? This year, we're doing one, we're actually encoring both of those this year, but we're also doing one called The Myth of Misbehavior and how to distinguish behaviors in children from symptoms. We're going to be doing one on differentiating bipolar from borderline personality disorder, which is extremely difficult to differentiate for many, many practitioners because we aren't trained with the tools to be able to tell the difference. We also have a clinical seminar that we did last year that we're encoring again this year called How the DSM Fails Providers and Their Patients. And we look at all of the problems that are with the DSM and why the DSM model often fails to help us accurately diagnose and treatment plan for our patients. And so we are constantly looking at new research. Our clinical seminar last fall on the science behind metabolic therapies and the use of the ketogenic diet to treat mental health conditions. We got some flack from some people for that. They said, well, this is too new. It's not too new. It's out there. It's cutting edge. It's where an enormous amount of funding in the field of mental health is going to right now. This new idea that bipolar disorder is an energy disorder. That a lot of people will immediately say, I don't think that's true. Bipolar is not an energy disorder. It's a disruption in brain chemistry. Uh,
Mhm.
okay, that's the prevailing wisdom. But right now, there are tens of millions of dollars that are being spent researching the vagus nerve, that are being spent, which is involved in digestion as well as in regulating our limbic system and our fight or flight response. There's research being done into the use of ketogenics to treat mood disorders. There's research being done looking at the mitochondria of cells and how the energy use in our cells influences our moods. So you can say that you don't think bipolar is an energy disorder all you like, but that doesn't change the fact that the current research is pushing in that direction, and it may very well turn out to be the case. Are we saying it's a fact? No, we're saying this is what's happening right now in the field, and we get it. Your caseloads are too full. Your administrative requirements are onerous, but we're out there connecting with these people, talking to these researchers, going through their published papers, engaging them on their turf, and bringing it back to you, the provider, so that you don't have to do all that legwork yourself. You can show up, listen, learn, come to a professional discussion group, delve into it deeper, get the pieces that you need to inform your work, um, without having to worry about um, doing all of that legwork yourself. So, these are things that we offer. All of the resources that are on the screen right now are things that we offer to help providers who are wedged between that rock and hard place of the demands of their job and the quality of care that they want to be able to give to their clients and patients.
Yeah, a lot of times, Elizabeth, people say, I want to know how to do exactly what you do, or I want your level of knowledge. And there's no real secret to it. I say this all the time. There really isn't. I listen to lectures on YouTube. There's lots of people from Harvard and from Stanford and from all kinds of great institutions who put their lectures. And it's not just about bipolar. If you're interested in OCD, whatever it is that you're passionate about, it is out there and it's available. There scholarly articles from NIMH are available to read through and to sift through, and they're there for you. And, there are so many podcasts. If there is someone that you're interested, or if there's someone who's an expert out there, they've probably been interviewed and they're easy to be able to listen to on your commute to and from work, on your walks if you want to, while you're cleaning your house. And so if that's what relaxes you, because you do want to put a boundary in there, but for some people it does. But there are websites that you can go to that are nonprofits like ours for the area that you're interested in. For us, we have a read, watch, listen zone. So it's not just us that is saying all of this. Anytime we find something interesting, um, we absolutely want to share it with other people. And we're like, hey, check out this interview. This is amazing. You might want to read this. And it's current research. It's
Yeah, Jen, I'm
great
just
stuff.
want everyone to know that I'm showing right now that page on our website that you're talking about. Read, watch, listen. It has we have articles that have been written just within the last few years. I mean, the number of things from 2023 is pretty significant. We have, and there are lots of papers. We have our watch section. These are videos that we're watching on YouTube, on other websites, other nonprofit websites like the International Society for Bipolar Disorders, the NAMI, National Alliance on Mental Illness, TED and TEDx. And we have podcasts right here. And if you are a professional and you have one and you think, oh, this is something I'm listening to that everyone should know about, send it to us. email us a link and we'll review it and put it up here so that the whole community can have access to it. And if you're coming to our professional discussion groups and peer supervision sessions, bring them along. I mean, that's what we're there for.
I know that we're getting, close to our time to end, but being passionate about what we do, staying engaged with what we do, what is current, what's on the up and coming, those things are a protection against burnout. And so that can keep us motivated and keep us interested in what's next and how to help engage our clients. So I just want to put that out there as well.
Absolutely. Um, was there anything else in the Q&A?
No, just more about how to find the slides. And I think, if you missed a slide, check back with our YouTube channel. It takes a little while to get that up and loaded, but all of our seminars and webinars, they will be filtered into our YouTube channel. So check back there and you can find what you're looking for.
And I'll just mention that as a sustaining member of CMHRC, you actually get a 30-day advanced priority access to all of our webinar, clinical seminar, educational and motivational video content that we put up on our YouTube page. You get access for 30 days prior to everyone else. And once a month, we send out links and information so that you can know exactly what it is that you have priority access to. So if you're interested in becoming a sustaining member, you can go to our website and do that and look under the menu tab on the top of the page that says membership. And we'll be able to make sure that you get it immediately. Otherwise, all of our video content, webinars and clinical seminars as they happen, they post 30 days after the fact. Okay. And the email again to request a certificate. You can email programs, PROGRAMS @CMHRC. Our learning team can also help with that. So you can email learning@cmhrc.org if you want to. Either one will get you. And if you lose that, don't worry about it. Go to our website, go to the contact us page and just shoot us an email that says, hey, I was at the event on such and such a date. I'd like to get a certificate. And then we can send it to you. And I think if there's one idea that I want to leave everyone with, and Jen, I'll give you the chance if you have anything that you want to leave folks with, it's that this organization exists because we are mental health providers who recognized that we weren't getting what we needed professionally from our working communities, and that we needed to come together and create something that specifically meets the needs of the mental health care professionals who work with children. And that's a pretty broad term when I say mental health professionals. I'm also talking about the occupational therapists, the speech and language pathologists, the folks who are paraprofessionals who work with kids in schools who have emotional issues is how they talk about it in schools, but psychiatric conditions, mental health challenges. If you work with kids or teens, if you work in the mental health field, we're here to support your work. So becoming a member of CMHRC, becoming a part of our community, it's what we're designed to do, is to meet the needs of families as they go through the mental health care system and meet the needs of the providers who are giving them the care that they're receiving. So we're here for you. And so we're eager to have you join our community and to be a part of what we're doing. Jen, is there anything you'd like to add?
No, other than I'm inspired by everyone who is out there, I guess Gen Z as we call it, and millennials, and how they're really creating that space and those boundaries, and saying, I'm only going to be working this much. And so that to me gives me hope that we are going, and that we not are going, but we are headed in the right direction. So we are moving there. And I know that some of us continue to work in with vulnerable populations where we still have a lot of work to do. But I also am inspired by the fact that we are making some significant changes as well.
Agreed. All right, everyone, thank you so much for being here. Next month, our webinar is on parent and caregiver self-care. So if you have clients, if you have parents of clients, if you have folks who are in the position of parenting, of being caregivers to kids or other adults with special needs, disabilities, psychiatric conditions, really anything, I highly recommend that they attend. The event is going to be on Wednesday, February 21st from 7:30 to 8:30 p.m. Eastern Time, and it is with a guest, a very special guest. Her name is Anne Reed. She is a life coach. She has a show on Bold Brave TV called "Be Happier in Spite of Your Life," and she is going to be with us to talk about the importance of self-care for parents and caregivers, and to give us some specific techniques and strategies to share with them. So if you'd like to join us for that, or encourage the folks that you work with to come join us for that, it's a free event open to the public, and we would just love to have you there. So thank you so much, everyone. We look forward to speaking with you again soon. Have a great rest of your day, and we'll see you next month. Bye,
Good night.
everyone.